Yeah, Dr. Arvind Chandna has done his MBBS from Maulana Azad Medical College. I learned from his biodata, and that's very nice because I've served there for 35 years. Only thing is that when he left, then I joined, so we never met each other. He is senior clinician, scientist, pediatric ophthalmologist, and adult strabismus surgeon at Smith Kettlewell Eye Research Institute, San Francisco, USA. We all know about this institute. Ex-consultant pediatric ophthalmologist and strabismus surgeon at Elder Hay Children's Hospital, Liverpool, UK, for 25 years. Interest to determine the relationship of accommodation and divergence in strabismus, assessment of patterns of visual function, loss in amblyopia, and cerebral visual impairment. Research programs investigate visual brain neuroscience and oculomotor behavior using eye tracking, photorefraction, psychoanalysis, and visually evoked brain potentials in childhood eye disease, psychophysics, I'm sorry. So over to Dr. Chandna, please.
Well, thank you very much. I am just about to share my screen. Hopefully that'll go well. Let me see. Thank you very much, Dr. Pandey, and obviously Professor Dadea, who initially contacted me to speak. So I'm just going to try and share my screen again. So could you see my screen now, or are you just seeing me?
Sorry, we are seeing too many slides. We are seeing the screen, but they are the spectrum of slides, not one slide.
So I'm starting my slideshow.
Yeah.
So you can see my slideshow?
Yeah, now we can see.
Thank you. Well, thank you very much again. And, there's a saying in England that I've worked for many years, that you wait at a bus stop and you wait a long time and no bus comes. And then two buses come at the same time. And this is the situation today. We've just heard a very illuminating talk on cerebral visual impairment, which in one way has made my job much easier to talk about. So I thank the previous speaker, but also made it very difficult because I'm going to repeat some of the things that have been said. But it is important that we have a lot more discussion on cerebral visual impairment as it becomes a very important disease within the field of pediatric ophthalmology and takes us away from the eye into the brain, where we have been treating a disease for a very long time called amblyopia, which is also a brain-based visual disorder, though some of its origins may start in the eye with anisometropia or misalignment, as in strabismus, but the effect of all that ocular disorder occurs in the brain. And most pediatric ophthalmologists and strabismus surgeons would know about this, except that adult ophthalmologists mostly focus on the eye itself. So I'm thankful to my organizations, which is the C Lab in Smith Kettlewell Eye Research Institute and the Older Hair Children's Hospital, where I worked and I continue to work part-time, and the organization Vision for Children, which is a charity that funded a lot of the work that I'm going to talk about. So I'd like to talk today about visual functional loss at multiple levels in cerebral visual impairment and take you beyond the eye for that aspect. So today, let me see, I'm going to divide my talk into two parts. Is CVI important? What is it? Where is the problem in CVI? Then move on to the next part, which as clinicians is very important when you're faced with a child or a parent in a family where you suspect CVI. How do you diagnose it? How do you assess the visual function loss? And what do you do about it? So those are the two parts I'll cover. Some of it will be the same as the previous talk, and some of it will be different. It is my personal approach as well. So first of all, is CVI important? So here is a pie chart showing you a recent study where all the children who were registered blind in the UK over some years were assessed for the reason of their visual impairment. So this is in 2014, and the prevalence has increased since then. The cerebral visual pathways were 40% compared to any other cause of pediatric childhood blind registration, which means visual acuity of both eyes open less than 624. So it turned out that CVI is the commonest cause of bilateral visual impairment in children in the developed or industrialized or economically advantaged country, whatever WHO definition you can use. However, the prevalence is rising in developing countries, in middle-income countries and low-income countries. And that is primarily because of the increasing prevalence of increasing incidence of premature birth, which is an epidemic around the world. And that was mentioned to a certain extent by a study from Bangladesh earlier today. And as you've heard in the last talk, we know that 23 to 30% of children may have some form of CVI within India itself. So moving on, what is cerebral visual impairment? Let me tell you what it is not, and it is often wrongly defined as cortical blindness. That's a very old term, and it is not blindness, first of all, because a large proportion of children with CVI have reasonably good visual acuity, or maybe even near normal visual acuity, a group that I will describe later on, and also been then moved on to call it cortical visual impairment. And we very well know now that the blindness or visual impairment is not related to this, not limited to the cerebral cortex. It is actually extends over the cerebrum, but also in the brainstem, with causing problems with eye movements. And now we also know, as we mentioned before, that due to retrograde synaptic degeneration, we can actually visibly see the changes in the eye itself. What it is a definition defined by consensus by a group of people, which is a verifiable visual dysfunction, which cannot be attributed to disorders of the anterior visual pathways, which means that you may have difficulties in the anterior visual pathways, but cannot be the impairment cannot be attributed to that, or any potentially co-occurring ocular impairment. Here, I'd like to bring out a very important point, which needs to be brought out more and more, that one of the common conditions that we've been treating for a very long time associated with premature birth, and has been discussed today as well, is retinopathy of prematurity. And premature birth is one of the highest risk factors of developing CVI. And therefore, children who have ROP may have visual impairment due to retinopathy of prematurity, but also may have visual impairment due to CVI, which needs to be looked at, assessed, and diagnosed separately. And we are missing the CVI in lots of children with ROP because we are focusing again and again just on the front of the eye, or sorry, in the eye itself. So that's something that we need to look at. What is my practical definition? So that was a definition. It's great. It solved the issue about cortical blindness and cortical visual impairment. Here is my experience of practical definition. This is my own personal opinion, and I welcome any other changes to it. So in clinical practice, CVI is typically diagnosed in a child by observation of abnormal, visually guided behaviors. That is, behaviors that rely on normal visual function. This means that any action that you do, and if you start looking after this conference as to how many things that you do which are entirely guided by vision, and it is those behaviors that are affected in children with CVI despite normal or near normal visual acuity sometimes. With a suitable clinical history that suggests abnormal brain development or brain damage. And we'll come to that in a moment. So in fact, it is a brain-based visual impairment. What is a holistic view of it? If you want to have a take-home message, then, or sorry, a message that look in the clinic, the eye looks normal. And we know now for various studies, which I'll show you, that the eye is not normal. The problem is actually in the brain areas that process vision, control eye movements, control focusing for near viewing, which means accommodation is hypotonic sometimes, not every time, causing problems with visual acuity, not always, and higher visual functions, oculomotor eye movement function. So it is an eye problem as well. Sensory, and what is very important is sensory motor integration. That means your vision integrates your motor behavior. So if you want to take home message, this is the holistic view. It is a brain-based, multi-dimensional impairment of visually guided behaviors, which means the title of my talk, the visual functional loss, is at multiple levels. So let's go where next thing is where is the problem in CVI that is beyond visual acuity? Let's take you on a journey behind the eye. The purpose of the eye is only one, that is to well-defined focused image on your fovea and the rest of the peripheral retina about your visual environment so it can be transmitted to the brain so that you can interpret what you can see. Obviously, the two eyes together do many other things like align themselves, but that is also controlled by the brain, not by the eye itself. So the eye is just a simple optical mechanism. And then you can see that as the visual pathway takes the message into the brain, the first time that you ever exchange information about your visual environment is in the primary visual cortex, sensorially. You may exchange structurally the fibers at the optic chiasm, but you don't actually analyze the image until you get to the primary visual cortex. And even at the primary visual cortex, the image is extremely basically analyzed. It is not analyzed in any detail. So where is the image analyzed so that you can actually understand it? So the problem in CVI actually lies in the associated visual areas to the primary visual cortex, such as the area V3, V4, V7, all the way into the parietal lobe, but mostly in the posterior parietal lobe. And then the other areas going into the temporal lobe here as the V8, and this is the occipitotemporal pathway, and this is the occipitoparietal pathway. So what you're understanding by looking at the talk or looking around you is all happening either here or here. So what is the distribution of the analysis within these things? So where is the problem? So Gordon Dutton, whom has been mentioned before, is the prime mover in this field. And back in the 1980s, he was shouting from the rooftops about CVI, and we were not listening. So where is the problem? The first problem that occurs in CVI is in the occipitoparietal pathway. And this, for various reasons, by Milner and Goodale, have been called the dorsal pathway, which is about the where and how. It produces a spatial map of the environment as you are sitting down or walking, navigation, and also computes motion as you walk or as you go anywhere. Where is the ventral pathway? The ventral pathway is the occipitotemporal pathway, and this is the who, what pathway. That means who is this? What is it? Is it text? Is it a face? And their facial expressions. However, what is important and recently realized that these two pathways are not separate. They're actually together. And so therefore, there are some interconnecting pathways, which are shown in the purple arrows here, which are integrating the dorsal and ventral pathway. And then finally, integrating the motor pathways, which run along here and communicate to the frontal lobe. So these interconnecting pathways are the ones that help to understand the connection between dorsal and ventral pathways. So these functions are not entirely separate. They are together through these interconnecting pathways. So now, what are the dorsal pathway issues? So when you have CVI, if you have dorsal pathway effect, you have motion deficits of two kinds. One is you may have akinetopsia. That means you actually do not see motion at all. Or you may have a different kind of motion pathway that you can only see things that are moving. These are two different issues within motion deficits. Simultagnosia, which means not being able to see more than two things at one time or more than four things at one time, which you take as a routine for yourselves, is the problem in CVI. And it underlines a large number of problems of poor spatial awareness, that means being able to see the whole crowded, cluttered visual environment, and inaccurate reaching as well. And more susceptible to damage from common cause of CVI is the dorsal pathway. The ventral pathway can also be damaged, and this creates problems with visual memory, just like in Alzheimer's disease, object and face recognition and recognizing of facial expressions, which actually means recognizing of face and problem with motion. So these are the interconnecting pathway deficits, and they are very common. Impaired visual search in your visual field, and simultagnosia underlines that. Difficulty splitting attention between two different objects, and divided attention test in babies is a very important test to pick up CVI. Impaired visual guidance of movement, which is the inaccurate reaching before or after an object. So moving on, simultagnosia. I just want to describe this deficit because it underlines a lot of problems. So the term simultagnosia was started by Woolpert in 1924, but there are many other aspects of simultagnosia that have been diagnosed. One thing I'd like to mention very importantly is these children are agnostic. That means they never ever developed these functions. Whereas if you lose your brain function later on in life due to trauma, tumors, vascular strokes, etc., you lose the ability that you developed. So most of these children are truly agnostic that you can actually see like we see. So they don't even know that you can pick up things in a crowd. They don't even know that you can recognize faces because they never developed that facility. So simultagnosia, just coming back to that, or any of these agnosias like motion, is the inability to recognize and sort out objects when they appear simultaneously. And all our world is full of simultaneous objects. They can't recognize them when they appear alone. Only can recognize them when they appear alone. They're unable to perceive the overall meaning of a picture, multiple things together, and is caused by damage to the parietal and superior occipital cortex, the dorsal pathway. Here is an example of what happens in simultagnosia. Here is a scene which is common, and it could be cartoons, it could be a live scene, and you tell the child, can you see the red car? And they can't, because the red car is amongst a lot of other surroundings and they have poor spatial mapping. Whereas what they do then is to blur everything else and then see the car. So they lose their whole peripheral field to be able to see anything. And that's why their navigation towards the red car becomes extremely impaired. So there are two kinds of simultagnosia. One of them is dorsal type, and I'm just going to quickly go over it, but it's basically about cannot see more than one object at a time. And the typical thing is this: you see a table, a jar, and then they might be able to say, oh, I can only see the table and the stool, or I can only see the part of the picture, or I can only see this thing and I can't see the stool. So that is very important to diagnose by simple tests. And the next one is the ventral type. So they are pretty interrelated. Those, for descriptive purposes, we define them separately. Is the cannot identify more than one object, cannot identify complex objects at one time. So here you might see that a night sky picture with stars and a full moon, they might identify the moon as a ball rather than the moon itself, because they cannot identify complex objects at one time with the stars. We move on to the second part of my talk, which is CVI important? What is CVI? Which is this part of the talk. How do you suspect CVI? How do you diagnose CVI? And how do you assess the function loss? And what do you do about it? So how do you suspect? I'm going to go over this quickly because this is already being discussed. These are all adverse events pre or at post-birth. The commonest lesion in CVI is periventricular leukomalacia, and this is an infarction around the posterior horn of the lateral ventricles, and it is around this area that the visual cortical pathway goes around and is accompanied by the motor pathway, and that's why you get cerebral palsy and CVI together. These are the lower limbs mostly get affected, so you get inferior cerebral palsy and CVI. And that's an MRI diagnosis of periventricular leukomalacia. The other very common one that's been mentioned is neonatal hypoglycemia. It could occur at term. And for some reason, when you have neonatal hypoglycemia, you have this problem of infarction around the occipital cortex. It's a predilection for the occipital cortex. And again, when your primary visual cortex is damaged, then you're obviously going to get damage of your dorsal and ventral stream. The other causes are straightforward, and you can look up any textbook for them. Going on again, how do you suspect? If a child has had premature birth, especially if they're extremely preterm, less than 28 weeks or very preterm, the incidence or the prevalence of CVI in these children is about 30%. Cerebral palsy, about 40%. Other causes are also important, and also it is important to realize that other brain-based learning disorders like autism, ADHD, and ADD could also cause these problems. So moving on, how do you suspect it? Again, you're in a clinic and you look for additional events or factors. For example, You have unexpected difficulty in focusing for near vision or reading in a 5 or 6-year-old when they do not have a refractive error, which means they have hypotonic accommodation, and they may improve with +3 diopter lenses, but only prescribe in the way they do. Unexpected result from strabismus surgery is the first time I was made aware of CVI, because my child, who had bilateral medial rectus resection for a straightforward esotropia, went exotropic immediately post-op, and doing a scan showed PVL, which had not been diagnosed before. Then when you give them glasses, they don't improve immediately, which means they have bilateral sort of CVI amblyopia, and it takes a long time for vision to improve. Problems with the inferior visual field, where they trip over everything, though it's visible to everybody else. Navigational difficulties through crowded rooms, clutter, school rooms, playgrounds are very important. Behavioral problems in these environments are the first symptom sometimes that the child is either withdrawn in the playground or running around bumping into everybody else. So a clinical diagnosis based on an evaluation by and communication with a multidisciplinary team and all the features that I've mentioned before. So moving on, if you want to diagnose CVI and from your suspicion of CVI, the most important thing is to do a structured history taking, which I will talk about in a moment. Assessment of visual behavior, assessment of visual acuity, a complete eye examination. I'd like to point out to you that there is an optic nerve head, which is typical of periventricular leukomalacia, and an ophthalmologist can diagnose PVL by looking into the eye. Electrodiagnostic tests are helpful, but not at the moment used clinically. Brain imaging is very important. And importantly, in visual acuity, recent evidence is coming out that if you do a crowded visual acuity in the logarithmic chart and you do a single letter acuity, there is a difference of 2 lines or more in CVI compared to normal children. But at the moment, the research is not solid. What is important is to look at the ganglion cell or nerve fiber layer, because there is enough evidence now to suggest that there are sectorial deficits in the ganglion cell or nerve fiber layer on OCT in CVI. Here is the example of a periventricular leukomalacia disc, which has a pink rim. This is not cupping or glaucoma. This is a large optic cup, which is called PVL disc. And it can, over a period of time, progress to optic atrophy. But this is a loss of fibers in the cerebral, in the visual pathway, that causes retrograde synaptic degeneration. Is the first early sign of PVL. It is present when PVL is present. There are some mythbusters about CVI diagnosis. So can CVI be diagnosed in the presence of normal visual acuity? Yes. Can it coexist with an ocular condition? Yes, with ROP. Be diagnosed in the presence of a normal MRI brain scan? Yes, because the MRI brain scan may not have the resolution to pick up all the subtle deficits that we are diagnosing now by tractography. Can it coexist with the brain-based learning, behavioral and motor problems like autism or cerebral palsy? Yes. Is the eye normal in CVI as been defined previously? No. So now I move on to your practical aspect of using a higher visual function question inventory to diagnose the CVI. This was started by Gordon Dutton, and we have modified it. And now I would like to present some results. So the characterization patterns of visual dysfunction was started by Gordon Dutton. This is the pattern of visual dysfunction in ventral stream deficits with recognition, etc. You can see most of them about recognition, and the dorsal stream, which is mostly about spatial mapping and navigation. So to get all these higher visual functions into a question inventory, Gordon Dutton designed a question inventory of 51 questions, to which now we've added 5, which are 56, and also produced a screening inventory of 11 questions. So this is based on this question inventory, which is a web-based app. And you can see there are simple questions like trip over toys and obstacles on the floor, and the parents answer this question inventory on the basis of the possibilities of a Likert score from never to always. And there are the research that we did was on 51 questions. There is also not applicable option if the child is in wheelchair. Once they've answered the question inventory, we score them as 0 to 4, and then move on to show you the results rather than going to the details. Here is a group of children who have CVI and visual acuity that is better than 20/40. Compared to normals at the same time. So the blue line is the normal. Here are all the questions in the x-axis. The y-axis shows the average score. Sorry, can I carry on? Yes, thank you. So the
Carry on
normal
for,
children are here. Sorry?
you can carry on for another writing 10 minutes maximum, 5 to 10 minutes.
Oh, no. I won't take 10 minutes. Thank you very much. Thank you for your patience. These are normal children who have a score of less than 2 or less than 1, actually. They're the same age match children. And these are children with CVI who have a score or mean score of 2 or more. And these circles and squares are the most relevant or the most discriminant questions. So this question inventory research produced a screening inventory and a possible screening inventory, of which has 11 questions, which we call the top 11. So we use the top 11 first, and if they are positive on that, then we go on to the detailed question inventory. Why do we need the detailed question inventory? Because we have a practical, everyday clinical tool, which is now a web-based app for eliciting higher visual function deficits, which you can use with any parent. And at the moment, it's in English. It is being translated into Hindi and other languages. And the parent answers the question either by themselves at home or with an interviewer, and they choose something and you click that and the question inventory progresses. And then eventually these are the questions that you can see. You can have a paper printed, but the important thing is that after you answer the detailed question inventory, you get strategies for the parent, the child, and the teacher to help and accommodate for the deficits at the moment. So for each question that has been answered, sometimes, always, or often, you get various strategies that you can use for the child to help them overcome their deficit. And these are habilitation. Remember, rehabilitation is when you lose something. These are habilitation things because these children never develop these issues. So now you can, there's my email address. If anybody who wish to try out this app, they're most welcome to write to me, and you're welcome to try this out. Moving on, in conclusion, is CVI important? Yes, it is. I've explained to you, it's one of the commonest causes of visual impairments. It is called visual function loss at multiple levels. It has a definite set of risk factors allowing you to suspect CVI. There's a semi-structured history taking and talking to the parents, which allows you to diagnose the higher visual function deficits in CVI. Remember, this does not diagnose CVI. CVI is to be diagnosed by you with the history and the examination. This is to pick up the higher visual function processing deficits in children with a semi-structured app. It requires a multidisciplinary. You must speak to the imaging person. You must get a neurologist on board, an occupational therapist or physiotherapist to include these strategies. It produces a spectrum of higher visual function deficits of visually guided behavior, and you now have strategies to accommodate and support the child's visual difficulties. So, one of the things, this is a famous slide of a million tree project done by somebody in California who's planting 1 million trees all over the world with native trees using seeds locally. And I use this picture a lot to show to older children or adults with CVI who cannot see the trees from the forest. They just see colors. They don't see the trees because it's too crowded for them. And a parent I was speaking to recently said, my child is now 13 years old and his blindness has been invisible because he had higher visual function deficits. And because you diagnose a CVI and produce a spectrum of higher visual functions, and because we've been doing the strategies for now 4 years, it is the eye specialist who made it visible to the world. So everybody needs to know that these children are suffering from visual function deficits, which we take as normal. And it is our duty to pick this condition up by suspecting factors, by doing a thorough eye examination, and by assessing them for their higher visual function deficits. Thank you very much.
Thank you, Dr. Chandna, for speaking on a very important topic. In fact, I have seen few patients, some children who have sort of a glaucomatous cupping, looks like a glaucoma, and they have been put on timolol and anti-glaucoma medications. That awareness is very important, I think, on this condition, and as you said, incidence is rising. So it's a very important aspect of our responsibility as ophthalmologists.